Today we are going to look at the control of respiration, and we've divided the talk into two parts. The first part will look at the physiology of respiratory control, and the second part will look at the control of respiration in different clinical settings in health and disease. As usual, we're going to start with a case. This is a 54-year-old chronic smoker with COPD who presents with shortness of breath, hypoxia, and a productive cough. He's moderately distressed, hypoxic, tachycardic. His blood pressure is normal. And he's been started on high-flow oxygen. 30 minutes later, the patient is drowsy and lethargic, responding only to pain. His oxygen saturations have improved, but her blood gas shows that his PCO2 is very high. The patient's oxygen is then stopped, and 10 minutes later, he's once again awake and alert. So what we're going to do is go through our talk on the control of ventilation and then come back to this patient. If you want, you can pause at this stage and see if you can give an explanation for what happened to the patient. So these are the objectives for these two talks. You can pause the video and have a more detailed read. But basically, we're going to look at the physiology of respiratory control and then apply it to clinical settings, both in health and in disease. Let's just look at the muscles of respiration to start with. So the main muscle of respiration during normal respiration is the diaphragm. In inspiration, the diaphragm contracts and flattens, and this increases the volume of the thoracic cavity, causing a negative pressure, and this leads to air flowing into the lungs so that the lungs expand to cater for that increase in thoracic volume. The intercostal muscles are also in play here. Although many authorities will describe them as muscles used during forced breathing or accessory muscles, the external oblique muscles, which cause the ribs to rise upwards and outwards, play a part in normal respiration. They cause an increased volume of the lower parts of the lung, whereas the internal and innermost muscles tend to drop the ribs and flatten the rib cage and are used as muscles of expiration. In patients who are short of breath, or in situations where we are trying to maximally increase our minute volume, so increase the volume of air moving in and out of the lung, accessory muscles may be used. These include chest muscles, such as the pectoralis major and minor, latissimus dorsi and serratus anterior, all of which apply a force to the ribs that cause them to move upwards and outwards, thus increasing the chest wall. Muscles of the neck, such as the scalene muscles and sternomastoid muscles, which are attached to the uppermost ribs and clavicle, lifting the upper part of the rib cage, pulling it upwards and forwards, increasing the volume. Again, muscles of inspiration. Conversely, the abdominal muscles increase intra-abdominal pressure when they contract, forcing the diaphragm up. So these muscles are active in expiration. Just a quick note on muscular activity in inspiration and expiration. In normal respiration, inspiration is active due to the contraction of mostly the diaphragm, but some of the other muscles mentioned here, whereas expiration is passive. During expiration, the muscles relax and the lung achieves its resting volume, which is the volume at the end of a normal expiration. So inspiration is active, expiration is passive. Let's look at the control of respiration. Let's just look at the brainstem. The respiratory center is based in the brainstem around the medulla and pons, and it's made up of a few nuclei, specifically the dorsal and ventral respiratory group and the pontine respiratory group. The dorsal respiratory group, when triggered, causes inspiration, whereas the ventral respiratory group controls expiration through cutting off of the inspiratory drive and therefore allowing the patient to exhale. The pontine centers, the apneustic and pneumotaxic centers, drive the cyclical nature of breathing. The apneustic center stimulates the dorsal respiratory group and therefore stimulates inspiration, whereas the pneumotaxic center is an antagonist to the apneustic center and works cyclically to stop the apneustic center, allow the respiratory muscles to relax, and allow passive expiration. The nuclei in the medulla then control the muscles of respiration via the phrenic nerve and the intercostal nerves. There are many different factors which affect the cyclicity and the activity of the respiratory center. And these can be divided into chemoreceptors, mechanoreceptors, the hypothalamus, and the cerebral cortex. There are chemoreceptors which detect oxygen levels in the blood, carbon dioxide levels in the blood, and the pH. The oxygen chemoreceptors are peripheral, situated in the carotid bodies, whereas the carbon dioxide and pH sensors are central, situated in the medulla. It should be noted that actually the central chemoreceptors really respond to a change in pH. So even with hypercarbia, remember that hypercarbia leads to respiratory acidosis, and it is that acidosis that stimulates the central chemoreceptors. The mechanoreceptors include receptors that work with respiratory muscles and can sense the stretching of the lungs and the contraction of the respiratory muscles, and that then feeds back to the respiratory center, causing either inhibition of muscle contraction or, when the stretch receptors are stretched enough, inhibition, and then followed by expiration. There are also mechanoreceptors in the skeletal muscle, which can lead to an increase in minute volume during exercise far before the exercise itself produces an increase in CO2. The hypothalamus works on the involuntary part of respiratory control through the production of stress hormones, the activation of the reticular activating system, and via these two mechanisms through the mediation of the autonomic nervous system, in particular the sympathetic nervous system. And finally, the cerebral cortex allows us voluntary control of respiration, so we can actively and voluntarily increase our minute volume and respiratory rate. I just want to mention the cough, swallowing, and gag reflexes, which are not part of this lecture, but which you need to know something about for your DM Part 1 and to fully understand respiratory control. So that was just the first short lecture in this series, looking at respiratory physiology and the control of respiration. If you have any questions, you can post them. You can bring them up in class. So in summary, we looked at the functioning of the respiratory center in the brainstem and the effects of chemoreceptors, mechanoreceptors, the hypothalamus, and the cerebral cortex on this control mechanism. Thank you.